Hi there and welcome to this section on hernias in the inguinal region. I'm hoping that you'll know about the three different types, but by the end of this section you'll be able to distinguish between the three types. So that's just Zara telling me that the case is ready on the table. So while I'm going off to do this case, what I would like you to do is look carefully at the anatomy of the inguinal region and see if you can work out the difference anatomically between those three hernias, and we'll go through them when I'm back. You could print this off, it's in the emergency surgical section on Blackboard, or just copy it from the screen. Why don't you label this while I'm off doing the case? Zara's getting impatient. So how did you get on with that? Hopefully most of you have got a diagram similar to this or labelled correctly, and certainly some of you, I suspect, probably just downloaded the labelled version, but make sure you've got a good understanding of the anatomy, because we're going to go through that and you need it for later. I'd quite like to talk about the three structures just going underneath the inguinal ligament. And it's important to know which order these are in. There's a really easy mnemonic to remember. Remember the mnemonic NAVY, standing for N for the femoral nerve, A for the femoral artery, and V for the femoral vein. The Y stands for Y-fronts. Now you need to cast your mind to the urology ward where you have those elderly gentlemen in their underpants. If you notice that the front of the pants is usually in a Y shape, there's often a catheter hanging out for one side. You as a modern generation, I'm sure you're all wearing boxers and Calvin Kleins, but as an older generation do remember the Jockey Wilson Y-fronts. If you remember this, you can always remember the order which they're in. The nerve is lateral and the Y-fronts are medial. It's really important for when you're taking a femoral blood sample, because you'll feel for the femoral artery in the middle, and you can always remember now that the vein is on the medial side of the artery. So you won't be putting your needle into the nerve laterally and causing the patient pain and discomfort. A simple mnemonic to remember where to put your needle. So we're talking about hernias. Let's get back onto the subject. Let's remind ourselves what a hernia is. A hernia is when an organ or structure is prolapsing through an abnormal defect in the structures which normally contain that organ or structure. So looking at the diagram, we can see two obvious places where that can occur. The first is through the deep inguinal ring, then along the canal, or it could come out directly through the superficial inguinal ring. Both of these types of inguinal hernias can end up going down into the scrotum. The third place is just below the inguinal ligament, next door to the femoral vein. And this is a weakness where hernias can come through. To try and determine what type of hernia a patient has got, we tend to reduce the hernia and try and control its reduction by placing a finger over where we think the neck can be. We then ask the patient to increase their abdominal pressure by coughing, and if we've got our fingers in the right place over the correct defect, the hernia should stay reduced and not prolapse out. In order to do that, let's first go to my cupboard. Let's relate that to the bony landmarks. In order to do that, let's first go to my cupboard and get out one of my many skeletons. So let's look at the bony landmarks of the inguinal ligament. If we start from laterally, we've got the anterior suprailiac spine. Then medially, we have the pubic tubercle. Between these 2 points is the inguinal ligament, and halfway between these 2 points is the midpoint of the inguinal ligament. That is the place where we can control an indirect inguinal hernia by pressure over the deep ring. The other type of hernia which we get in the inguinal region is a direct inguinal hernia. These come directly through the conjoint tendon and through the superficial inguinal ring, which lies above and medial to the pubic tubercle. There they can come out and then go down into the scrotum. So above and medial to the pubic tubercle. If pressure controls the hernia by pressing above and medial to the pubic tubercle, it could be a direct inguinal hernia or possibly still an indirect hernia which has come down from above. The third hernia we see in this region is actually a femoral hernia. And these come out just medial to the femoral vein below the inguinal ligament, just in this region here, adjacent to the lacunar ligament. If you can only control your hernia by applying pressure below and lateral to the pubic tubercle, it must therefore be a femoral hernia, because a indirect or direct inguinal hernia will still come out and down above where you're trying to control the neck of the hernia. The other bony landmark is the symphysis pubis, which is the midline. Halfway between the symphysis pubis and the anterior iliac spine is the mid-inguinal point. This is slightly medial, and pressure over that area is where we can feel the femoral pulse, where we're pushing the femoral artery against the acetabulum. Well, hopefully that's given you a really good overview of the inguinal region, the hernias we see in that region, and where they are in relation to the bony landmarks, but also the artery and the vein. You can take that to surgical outpatients and onto the ward. Good luck.